Okay, so yesterday we were talking about the parts of the endotracheal tube. I kind of explained already the different parts, the patient end and the machine end, um, connector, the cuff, and the pilot, balloon, and valve. And again, if you open these PowerPoints in notes view, there's a way to view the gray box underneath that has some extra notes. But basically, the beveled edge with the cuff is the part that goes into the trachea, and the tip of the tube here is, and at the end, if it's a Murphy tube, it has an eye or a hole on the side, and that's how you know it's a Murphy's tube, which is the most common endotracheal tube. Again, unless you're really working with exotics, you won't usually use a Cole tube. Your clinic may not even have any of them. And then this cuff is what I'm going to explain, and this is how we inflate it. And again, somewhere around week 8, we will get in the building, and you can practice blowing up this cuff and doing this. Now, there's a couple different kinds of cuffs. The most common is the low volume, high pressure, and you've got the high volume, low pressure. These cuffs, and kind of what I do week 8 is I will blow one up and see how big we can make it. You'd be amazed at how many syringefuls you can get into this cuff. The cuffless tubes are used in the exotics to minimize tracheal damage. I just really want you to know why we inflate the cuff. And really, and this is something that's not necessarily in the notes, but I want you to know is what is the purpose of inflating the cuff. First of all, it protects against aspiration. If you put it in and you blow up the cuff, and then it fills up the entire trachea, if they were to vomit or have regurgitation, it prevents aspiration into the lungs. And you don't want to get stomach contents in the lungs, because obviously regurgitated fluid, stomach fluid, has a very high acid content, can cause a lot of irritation to the lungs, and can progress to a pneumonia, and they can get very sick. So we want to try to prevent aspiration. I think I've mentioned this once before. If you were to start to induce a dog, because when you give them the induction agent, they lose their swallow reflex and they lose their cough reflex, which is one way they protect their airway. If they're to start to vomit or regurgitate, you need to hang their head over the table. You don't want to lift their head up, because then that'll cause contents to go down the trachea. And if you have a tube in place, you want to fill the cuff immediately to try and prevent any aspiration. And so that's what you do, because sometimes dogs will vomit or regurgitate during induction. It's not common, but it can happen, and that's the first thing I do. And like I said, don't worry about getting it on the table, on the floor, on your shoe. I don't care. You just want to prevent it from getting in the lungs. So that's your goal. So it protects the airway. It also prevents leakage of anesthetic gas, because when gas goes in the tube into the trachea, if that cuff is not inflated, it can leak out of the mouth, and we can get escape of what we call waste anesthetic gas. The one thing the cuff does not do, it is not supposed to be tight enough that the tube cannot be pulled out. It does not hold the tube in place, and some people make that problem, or they make that mistake on a test. They say it holds the tube in the trachea. There have been many occasions where we have ended surgery and I've had a patient begin to swallow or chew. They start to bite on the tube immediately. And ideally, when you go to remove the tube during recovery, you always deflate the cuff. So you take the air out of the cuff so you can pull the tube out. There have been times, and it's not ideal, where the animal was they woke up too quick, and I've had to pull the tube out immediately with the cuff inflated, because I would rather do that than have an animal bite the tube in half and swallow the endotracheal tube. And on emergency, I've had 2 occasions where we were sent an animal that was from a clinic and it bit the tube and it swallowed the tube, and we had to go in and fish out the tube out of the trachea. So it can happen where they can bite the tube and immediately, as soon as you start to see chewing, you don't want to be trying to find a syringe and taking the air out of your cuff. And if that cuff was too tight and you couldn't pull the tube out, that would be a problem. So it's never meant to hold the tube. You only want to put enough air to fill the trachea. And like I explained to you guys yesterday, you want to always put the biggest tube you can in a patient. One of the cases where we had an animal that swallowed an endotracheal tube, it was a Rottweiler, and he had been neutered at the spay and neuter clinic, one of the low-cost spay neuter clinics. And when we went in and fished out the endotracheal tube, when we pulled it out, it was a size 8 endotracheal tube. Now, a Rottweiler, an adult Rottweiler on average, is probably going to take, like an 11 or a 12 endotracheal tube. I usually put an 8 in like a beagle, a Cocker Spaniel. These are just kind of averages over time. And so that was a very small tube for that size of dog. You can get a small tube in a dog, but the problem is then you have to put a lot of air in that cuff and you put more pressure in the cuff. And the problem is over time in the trachea, that cuff does put pressure against the wall of the trachea. And if you remember, the inner lining of the trachea is lined with mucosa, which is a very sensitive tissue. So we have to be careful how much pressure. Now, if it's like if it's a spay, a neuter, a quick dental, that pressure is not going to cause a huge amount of trouble. But if you're in specialty work, emergency, and sometimes we have long surgeries, if that cuff is inflated tightly for a long period of time, it compromises the blood flow to that area and can cause irritation. So ideally, and when we put air in, you usually, and I'll show you when we explain it in week 8, but you kind of put air in until you get a little bit of pressure. There's not an amount. I can't say always put 5 mils or 10 mils of air. It's going to depend on the animal and the size tube. So what you do is you usually push a little bit of air in, and when you get a little bit of pressure, I release back and stop putting in air. So you just have to be careful with how much air you put in the cuff. Now, a laryngoscope, not every clinic, every clinic should have a laryngoscope. It would be rare, but a laryngoscope is used to visualize the back of the throat and to actually see the larynx. Now, when you go to intubate, someone's going to open the mouth for you, and someone usually holds the tongue for me. And then I usually take the laryngoscope with my left hand, because I'm right-handed, and I use it to push down the tongue, and I can look, and it has a light. And I can look back there and I can see the larynx. So it helps visualize the area. It has a handle that has, usually has batteries in it, or sometimes the handle can be plugged in the wall to charge. And it has a blade to depress the tongue and the epiglottis, but I will talk about that. And it has a light. The sizes, don't worry about the numbers. Let me talk about the 2 types of blades. There's a Miller blade and a Macintosh blade. Now, the most common that we have is the straight one, which is right here, which is a Miller blade. And the Macintosh blade is curved and a Miller is straight. Now, if you look at letter E, the handles are universal. And I will also demo this week 8. You can take off this blade, it pops off, and you can use one handle and switch out the blades. Now, humans, they usually use a Macintosh curved blade because we have a natural curve, and so do pigs. So pigs have more of a curve to their trachea. But for most patients, the straight Miller blade is the most common type of blade that we will use. Now, let me explain. Sometimes when people have a laryngoscope, they reach way back there, and I am not a fan of touching the epiglottis, because the epiglottis, if you remember anatomy, the epiglottis is a flap that covers the larynx. Now, the larynx is your arytenoid cartilages and your vocal cord. So when an animal inhales, the arytenoids open, they pull open, and then you can see the opening to the trachea. Now, the epiglottis, sometimes when an animal is asleep, that epiglottis kind of gets stuck under their palate. So sometimes you look back there. I've had many students go, I don't see the trachea. I don't see anything. I usually use my endotracheal tube because it's soft, and I reach back and I take the epiglottis and pull it down. Because now this blade is a blunt blade. It's not sharp, but I would rather take my endotracheal tube and kind of push the epiglottis down. And then I use my laryngoscope to kind of push the base of their tongue down. And if you push their tongue down, it kind of pulls open the epiglottis and the airway. And when I talk about cats, cats are extremely sensitive in their larynx. They're prone to what's called laryngospasm. And if you even touch their epiglottis or near their larynx with a laryngoscope or a tube, a lot of times a cat will spasm shut. Sometimes cows, and especially calves or baby cows, not cats, calves. A lot of times they are prone to laryngospasm as well. So you have to be careful. It's really like an aim. So you don't want to touch back there with the laryngoscope blade. It's really just used as a light source. And a point of contention with me is because over the years when I've worked with tech students and vet students, and I'm supposed to supervise intubation, and I had this one vet student, and he was real, thought he was just the greatest thing since sliced bread, and he's like, oh, I don't need a laryngoscope. No, I don't use those. And I was like, well, you're here, and part of your skills is showing me that you can do this. And sometimes people, it's kind of, I don't know if they think it's a badge of honor and go, I don't need that. You're in school, you will use it. I'm not going to think less of somebody. Like I said, I've been doing this over 27 years. I use a laryngoscope. Can I intubate without a laryngoscope? I sure can. But if I have it, I'm going to use it. It's going to make it easier. My goal is to intubate them as quickly as possible. I don't want to make it difficult. Now, if you go to a clinic like in Timbuktu and they don't have a laryngoscope, you can make what's called a poor man's laryngoscope. And I take a tongue depressor and just get a cheap pen light, and you can tape the pen light to the tongue depressor, and then you can push on the light and use the tongue depressor to push down the tongue. So even if you don't have a laryngoscope and you can't see back there, because I'm telling you, sometimes these dogs, they have a very deep throat, like you can't see well back there. And again, once they're anesthetized and they lose that swallow, our goal is to get the tube in as quickly as possible, and the laryngoscope is just going to help. So I'm a fan of the laryngoscope. You also should clean the blade. A lot of people, I find them in drawers kind of cut. Usually I just take an alcohol wipe and wipe off the blade when I'm done with it, because you don't want to submerge this blade in any cleaner. Again, there's a little light bulb right here, and sometimes that light bulb gets kind of gunky. And also sometimes a little tip, that light bulb sometimes can get hot. We used to have one in oncology, and I used it in cats, a small blade. And man, I went to pop open the light, and then I touched it against my hand, and I could have burned my hand. And that's rare. That light shouldn't get hot. We ended up getting a new blade. But, so just be careful. If the light gets too hot, that's abnormal, and it shouldn't do that. Anesthetic masks, part of the equipment you'll usually have at a clinic, and they're a cone shape. They're usually clear, and they have a black rubber gasket. Let me show you the picture here. So these masks come in different sizes, as you can see here. And so in this picture, nice stuffed animal, you can see this tubing right here is the rebreathing system. So one tube here is bringing anesthetic gas and oxygen, and the other tube is where they're exhaling from. So they inhale and they exhale. Now, the mask, and then, they make them all the way down to, you can use these for exotics, pediatric patients. We've got big ones that you can use. The nice thing is the rubber gasket is supposed to put a better seal. If you are using a mask to deliver oxygen and anesthetic, you should have the gasket on. But a tip, sometimes we use these masks to give oxygen to patients. Sometimes if I want to pre-oxygenate, sometimes like if I have like a bulldog or a dog that I'm worried about breathing, and sometimes I'll give them oxygen for 5 minutes before, like the propofol. It's called pre-oxygenation. But sometimes, so if I'm using it for oxygen, some dogs don't like the feeling of that black rubber, like holding their mouth shut. I mean, I don't know how many times you've tried to hold a dog's mouth shut, and they sometimes fight. If I'm just using it for oxygen, you can take off that black rubber gasket just peels off. It's kind of hard to put back on, but you can peel it off and then just use the plastic cone. One time on emergency, we saw a hypoglycemic hamster. It came in for not eating. It was comatose. We put some Caro syrup on its gums, and we put it under one of these big masks, and we gave it oxygen. So we had it laying on the table, and we just put the mask over the little, what did I say, hamster gerbil, one of these little guys. We put some seeds in there and some gluten, and all of a sudden he just jumped up and he started grooming and he started eating the seeds, but we made like a little oxygen chamber over this guy. So you can get creative and use these masks in different ways, but basically they can be used for induction. You can also say this was a patient that you just had to pull some stitches out or draw some blood or take a quick x-ray. You can leave them on a mask as maintenance and not intubate them. So sometimes we'll keep a patient on a mask, but the downsides to a mask, well, first of all, it can be stressful for the patient. And when an animal stresses and fights you, they're releasing catecholamines, and their blood pressure's high. They can get cardiac arrhythmias. Also, if you have a dog like, I think about like a Shih Tzu or a Pekingese, and they've got those big eyes and the short mouth, sometimes I've seen people having the mask and they're pushing it into their eyeballs. So you have to kind of be careful that when you push the mask on, you're not pushing it into their eyes and hurting their eyes. So there's things to be cautious of, but you can leave it on them. You can use a mask for induction. You can leave it on for maintenance. Sometimes that's done with exotics. They'll just mask, because sometimes it's hard to intubate rabbits and a rat or things like that. So sometimes in exotics it's used as to keep them asleep. Again, the other thing I worry about is that you're going to get a lot of waste anesthetic gas. In your book, it describes how to do it, kind of like the process of induction. The other thing is, I would not mask a brachycephalic breed. When you mask a patient for induction or you maintain them, you are relying on them breathing in the oxygen anesthetic through the nose, through the nasopharynx, through the trachea, all the way down to the lungs. They have to be able to move air. And any brachycephalic, all of this anatomy is compressed and they don't have good airflow. Whenever you're masking a patient, somebody needs to be watching how they're breathing and are they having increased effort. Because if all of a sudden you have a patient that's like they're gasping, I mean, maybe they're not breathing in, and that's a patient you probably need to IV induce and intubate. So it's not ideal. Like I said, I use this a lot. We use this on emergencies. Sometimes an animal gets rushed back and it needs oxygen. And again, your anesthetic machine, if you don't have a vaporizer turned on, it is a lot of times used to deliver oxygen to a patient that needs it, as long as your vaporizer is not on. And this has happened where people forgot to turn off the vaporizer, and then a patient gets rushed back and someone goes to turn on oxygen for the patient and they don't realize the vaporizer was left on, and then you're delivering anesthetic. So always make sure, if you're using an anesthesia machine for oxygen delivery, make sure the vaporizer isn't turned on. That's key. And then most clinics, and not everybody does this, is there's anesthetic chambers, and it looks like sometimes called an aquarium. So someone's like, get the cat aquarium. And if they say that, it's like a box. And so let's look at the picture first. So it's usually about the size of an average fish aquarium, mostly used for cats, although I did use it at Purdue. We had a psychotic Shih Tzu, and it was a fairly small Shih Tzu. And the guy I worked with, he reached in with the box and scooped up the dog as he was trying to murder us. And then I flipped the lid on really quick. It takes some coordination. The poor dog was kind of wedged in there, but you know, again, I mostly use this for cats, but you can also use chambers for exotics. And if you use them for exotics, they do make these in different sizes. You can get small, because if you were going to use this to induce a rat, that's a lot of space. Okay. You want to try, sometimes if you had this, you can fill it with towels to try to make it smaller. That'll take up some of the space. But so what you do is you usually have the animal in the chamber. Sometimes I use the chamber to scoop them up. Sometimes someone's good at grabbing them with the gloves and putting them in the box. We put on the lid, and then usually the chamber comes with its own tubing. One tube hooks up to the inhalation and one tube hooks up to the exhalation. So one tube brings in oxygen and anesthetic, and one takes it out, because they have to have a way for gases to leave. And you don't want to leave this open, because then you'd have a bunch of waste anesthetic gas. But mostly this technique is used for fractious animals. That's the advantage to a chamber. It's extremely stressful on the patient. So really we don't want to use it, unless they're absolutely unhandleable. So, and then normally what you do is you'll turn on your oxygen and you'll turn on your anesthetic. Hang on, something is at the back door. Hold on one second. It might be, I'm sorry. Okay, so chamber induction really should be, again, aggressive patients is probably the main advantage. Feral, vicious, intractable. I had a client with a terrible cat, and she would put it in the box for us. I'd take the box in the exam room. She would put the cat, and she knew her cat was awful. And then I would get the carrier when it was kind of extubated, half recovered. I'd put the cat in the carrier and then give it back to the owner. So the disadvantage, and they're usually made of acrylic and you can clean them fairly easily. You can't monitor the patient closely. So you don't want to open this and take a heart rate. So all I can really do is I look at their eye position, I count and watch their respiration. Sometimes they'll get themselves wedged in really odd positions. They'll shove themselves in the corner. And sometimes I have to move the box back and forth to kind of get them away from the corner. Sometimes they'll shove their lip and I can look at their color, But the big downside to this, it's extremely stressful for the patient. Also, when you take this lid off, you're going to get a blast of anesthetic gas. So normally I try to have one person kind of take the lid off and take the box. And then when they're out of the box, usually you're going to do it till they're in like stage 3 plane 1. You usually bring them out. You'll try to intubate them. And then you can put them on, the tube and hook them up to the breathing system. Sometimes when they come out of the box, I have to put them on a mask because they're not completely asleep. then I intubate, and then I maintain them. So this is typically your induction. So usually these guys, sometimes you can't even get a pre-med in them. So most of the time you put them in the box, you put them on usually the very high percentage of gas. When they're asleep and you get them out, what we used to do is then put in their IV catheter, and sometimes I'd give them an injection of like a pain med or something, you know, because it was like I couldn't give it when they were awake. So, and again, there's a lot of better ways now to anesthetize them. Again, this is extreme situations, and there are some people that will refuse to box cats down. So if someone says we're going to box them down, this is what they mean. They're going to put them in the chamber. Are there any questions about those pieces of equipment? Okay, so now we're going to get into the machine parts. And the advantage of the machine is that you are going to deliver precise amounts of anesthetic and oxygen, because oxygen is the carrier gas, in a controlled setting. Because the machine, you can set your oxygen flow, you can set your percentage of gas, and it's all enclosed in the breathing system. There's a scavenge system that takes waste gas away, so it's enclosed, precise amounts. In this picture, I mean, there's a note about cost of machines. I mean, it's a variety of costs. Now, if we look at the machine on the left, this is a large animal machine, and it's pretty much the same as a small animal machine, except everything's bigger. The one thing that's different on the large animal machine is this piece right here. And again, these pictures are in your book, so you can look at them up close, but this is a ventilator. And normally, like I said, if you have a horse under general anesthesia, they're usually going to put directly on a ventilator. They don't breathe well on their own. So typically we'll do what's called controlled ventilation and put them on a ventilator that will breathe for them to ensure we get good inflation of the lungs and good gas exchange. But there's basically an oxygen source, the breathing tube, a rebreathing bag, a vaporizer, and then the small animal machine has got, you know, the oxygen here, we've got the breathing system, and we're going to go through all these parts. The cutoff is about 300 pounds. So, you know, in our large animal hospital at Purdue, we had small animal machines because you sometimes have to anesthetize a foal, a calf, a goat, a pig. You know, sometimes you've got smaller large animals that could go on a small animal machine. But if we're about 300 pounds and up, then they were usually put on one of the large animal units that is bigger here. And then, for example, when we get into breathing bags, this large bag right here, it's kind of hard to see in this picture, is about a 30-liter bag. The maximum size we go in large animal or small animal is a 5-liter bag. So that's 6 times the bag size. So in large animal, we typically use a 15 or a 30-liter bag. Now, if we're going to start, now, just like when I talk about the flow of blood through the heart, let's talk about the flow of oxygen and how it travels through the machine. You have to start with the oxygen source. Oxygen is our carrier gas. It says nitrous oxide. We do not use nitrous oxide as our carrier gas. Usually nitrous is what we call, like I said, I've explained, it's an adjunct. It's an add-on used to enhance analgesia. Oxygen is the carrier. And then you have to have a liquid anesthetic vaporized, typically isoflurane or sevoflurane. When oxygen travels through a vaporizer, because I've already talked about vaporizers, it picks up, it vaporizes the liquid anesthetic, delivers it to the patient, and then the machine has to have a way for the exhaled gases to leave the patient and to be safely taken away. And that's via a scavenge system. So the scavenging system, some is going to get recirculated and some is going to leave the scavenge system. But let's start at AJ. I'm going to murder my dog. The Compressed gas supply is going to be our oxygen source. Um, your vaporizer that we currently use most commonly today, if you remember, is a precision vaporizer, which is a VOC, vaporizer out of circuit. Again, old machines use the VIC, non-precision, but the current machines have a VOC, precision vaporizer. We'll talk about the breathing circuits that we use, which is a rebreathing or non-rebreathing. And then the end of the machine has a scavenge system. So if we look at this diagram, which could be on the test, so we just want to make sure we understand. I'm going to show you briefly, you have an oxygen source, and it's going to travel through these gauges I'll talk about into the flow meter. When you turn on your flow meter, that turns on your oxygen to the patient. It's going to go through the vaporizer, pick up the anesthetic. It's going to go into a tubing, which is called the fresh gas inlet. So that's oxygen and inhalant. They're going to come into the breathing circuit, and it has to go through something called the inhalation valve. When an animal inhales, that valve is going to pop open, and then the patient inhales through these kind of like, they look like wrinkled, this is the breathing tubes. The reason that they're kind of wrinkled like that, it helps mix the gas. That's why it's not a solid, smooth tube. It causes mixing of the gas, but they inhale through the Y piece. Now, right at this red arrow, that's where the endotracheal tube hooks up. So this red arrow is going to the patient. They inhale. When they exhale, which is some of the recycled gas and CO2, that's what they exhale, goes through the exhalation tube, out an exhalation valve. When they exhale, an exhalation valve opens, and the exhaled gases travel through that canister, that soda lime canister, and those granules, those little white, looks like white gravel, those granules will absorb the CO2. And then through this tubing, it goes, some of it's going to pass through a pressure manometer, some is going to go into the patient's rebreathing bag. So that bag is going to have some recycled exhaled gases, and some is going to go out this tubing, which is called the scavenge tubing. And then that leaves the system, and then it repeats itself. Now, when the animal's on the machine, your oxygen and vaporizer are on at all times. So there is a constant flow of fresh gas, okay? Think about this for a second. If an animal is not breathing, because if they're only breathing 8 times a minute, there's going to be a pause in breathing. If they're not inhaling, your fresh gas is going to go through the tubing, pass through here, and keep your bag full. So your rebreathing bag should always have gas in it. I never want to see that bag flat. If that bag's flat, you either have a leak, the patient can't breathe. If they inhale, they'll collapse the bag and they can't inhale. So there always has to be some gas in that bag. And that bag is a mixture of fresh and recycled gases. It's a mixture. But again, the key here is that soda lime removes the CO2 so we can rebreathe and recycle gases. Let me stop here. Or the only thing I want to show on this picture is we're going to go through all these parts. Okay, we're going to break down all these parts. As a reminder, on your Moodle page, there is a video that I posted, and there's a guy, he goes through all of the parts, the flow, talks about the parts. You really need to watch that video. It's about 15 minutes, but if you can spend 15 minutes on Snapchat or whatever, you can watch the video. It'll be useful. And then there's a second one that talks about hooking up the breathing systems, but I personally would watch the other video first because I haven't talked about breathing systems yet. Do you have any questions? Sorry, he's destroying something upstairs.